Hello everybody and welcome to this episode of Infection Control Matters. It's Martin Kiernan here and I've got one of my favourite topics to talk about today. And my special guest is somebody who has been working on this for quite some time. And it's Dr Rebecca Crapanzano-Sigafoos, who is the Executive Director for the Centre of Research, Practice and Innovation at APIC, but is an infection preventionist by background. And firstly, Rebecca, thanks very much for having a chat to me about this.
Absolutely. Glad to be here.
And secondly, you've been working on this for quite some time, haven't you? Because I remember a paper from 2018 where you were working, I think, in a large organisation and you wanted to do some work on staffing and outcome metrics. Could you talk to me about how you first got interested in getting the right number of infection prevention team members per organisation?
Sure. It was a very organic interest into this topic. So back in 2015, I took over a role as a director for, at the time, a 34 hospital organization. And eventually that organization grew to 54 hospitals. And I was tasked with structuring the existing infection prevention department in a way that made sense so that we could operate as a system. And as I started to figure out how I was going to achieve that task, I realized that what was available in the literature around staffing was just simply not sufficient to be able to help me to make good decisions. And so at that time, my team decided that we were going to take a very granular approach to trying to understand how we would staff our department. And that involved a comprehensive needs assessment, time studies, and developing a process that eventually has led us to the point where we've been able to share with others and ultimately develop a calculator to help others that don't have the time or the resources to be able to do such a granular approach.
Because presumably you've got a large number of organisations under your remit, but they were all presumably different sizes and with different needs, as it were, in the terms of the services they're undertaking. Is that right?
That's exactly right. It was, hospitals, ambulatory clinics, long-term care facilities across 7 states, critical access hospitals as small as, 5 or 6 beds, and large tertiary care facilities nearing 700 beds. And so, as you can imagine, the needs are quite different in each of those different care settings. And applying a statistic, which is really all we had at the time, of one IP to X number of beds, just that one size model does not fit all.
Yeah, especially not if you've only got 5 beds. That's
right,
going to make things
exactly.
somewhat challenging. Okay, so how did you actually go about that then? How did you break down what activities needed to be done? Because I've sometimes found that infection prevention teams set their own program to fit the team they've got rather than get the team they need to do the program they would like to do. Is that what you found, really?
Yeah, exactly that. And the variability across the different programs was really surprising. How, some teams prioritized surveillance and really were doing surveillance that wasn't required and, didn't necessarily make sense. And their own facility risk assessment didn't necessarily make sense for them. We started with a literature review, which is, kind of the way all of these type projects starts, and found a paper that highlighted here are the things an IP should spend their time doing. And so that was kind of the foundation. We used the APIC competency model as well. And then we surveyed the IPs at our facilities and asked them, are these all of the things that you're doing, or is there more? And one thing that came up was meetings. There's so many meetings. And a lot of those meetings, IPs were just included because, they know we're important, but, it may not be a meeting where we're actually contributing anything. And
although there's often a fear of missing out if you don't go to a meeting. That's what I've found.
That's exactly right. That
better go to that
FOMO is real.
Because if I'm not there, I may make a bad decision. So, okay.
Exactly. So, we started with that. And then using all of those data points, we put together a time study, and all of the IPs then collected their time across a couple of weeks to let us know, here's how much time I actually spend doing these different things. And then to try and understand what should we be doing, we looked at each hospital and we said, okay, how many units do you have? Inpatient units do you have? How many of those are ICUs? How many of those are, other kind of higher risk rehab units, burn units, et cetera? And then in an ideal world, how often would you like your IP to visit that unit? And how long would you expect them to be there? And, if we're doing routine rounding and having an IP be present, either during, standard multidisciplinary rounds or just walking through and making sure that, the isolation signs are on the door and, doing a quick view, scan of the environment, being present so that if somebody has a question, that sort of thing. And each facility decided for themselves, like what would be ideal here is we visit, we go to multidisciplinary rounds in the ICU 3 times per week, and that takes a half hour each time. And when you think about it that way versus a ratio, you're able to say, well, there's a calculation, right? Three times per week, a half hour each time is an hour and a half. And so we need to make sure that we've got an hour and a half each week dedicated to this. When you add that on top of all of the other tasks that an IP needs to perform in their time studies, so surveillance and meetings and all of those other things, then you're able to really put together a model of here's how much time we actually need to have a subject matter expert in the building in order for our program to run in the way that we want it to run. And so that's kind of the foundation.
A little thought just popped into my mind then. So you can say you got up to a 700-bedded facility. The ITU is at the wrong end. You've only got half an hour on that unit, but there's a fair amount of travel time actually moving around between these different departments. Did you manage to factor that in, or did you just take into account the time spent actually on these units? Because I spent a long time walking the corridors. Not that that's necessarily a bad thing, because people tend to ask you things while you're walking around, which can be good or not good. But did you factor in movement time as well into this?
So in the initial version, we didn't, not within the hospital. We did factor in movement time when we looked at the ambulatory clinics, though.
Sure.
And understanding there was all drive time. Lots of the clinics weren't located where the hospital was, and maybe even an hour and a half drive away. So we put that into the calculation there, but not inside the body of the hospital. Although, that makes sense, right? That's just one more, bit of time, ultimately, even if it's 3 or 4 minutes, across the course of a day, that adds up.
Yeah. Okay. Surveillance, I know on your side of the world is very important because there's a certain amount you absolutely have to do. Were you able to guesstimate or estimate how much of the team time was actually taken up with unavoidable surveillance that was mandated for you?
Yeah, most of it is what we ended up finding in that original study, that the surveillance burden was so high. And so we tried to tease that out and look at, how much of this is required, and, either by the state or by, the federal government. And which is different, right? Across our 50 states, there are some that have much, much higher surveillance burdens than other. Notifiable disease reporting, all of that kind of falls into that bucket. And then at each hospital, we decided, yes, you may have been doing surveillance on all surgical site infections for the last 20 years, but how much value is that provided? How many infections have you actually identified? And with that, then we're able to back off and kind of right-size the surveillance to make sure we were, checking the box on the things that were required and doing additional surveillance in areas where the risk truly did represent the need.
Okay. And what about education component? Because certainly in the UK, infection prevention teams will spend quite a lot of their time trying to educate people and motivate people to do the right thing. Did you find that to be a significant component, or would that be included in your rounding aspect?
So we utilized the paper that I mentioned was a paper by Sue Barnes and a number of other folks. And we utilized the reference from that paper for recommended time spent doing education. I can't recall now, this many years later, what that actual percentage was, but because education isn't necessarily done on a day-to-day basis. The development of education can take a lot of time, right? Creating modules and deliverable material, that sort of thing. We use just a standard estimate across all of our facilities to estimate educational needs.
Okay, thank you. And the last quick question about this section of it is that there was a very small amount of time actually allocated to the development of the people in the team. I mean, that was less than an hour a week.
Right.
So is the expectation that people will professionally develop themselves in their own time, or was it just the organisation wouldn't allocate them time, or that they had chosen, well, we just can't fit it in? What do you think that was?
I think all of those three, unfortunately, seems to be the lowest priority, because there's so much work being crammed into the 40-hour typical work week that in order to get everything else accomplished, that's the one area that always seems to be the lowest priority. Many of our IPs were working more than 40 hours a week. And so that was a significant finding for us. But since that publication, and really in my new role leading a research division, that's become a real area of interest for me. That how do IPs grow and develop if they don't have that opportunity? And I think it's really one of the reasons that when we look at the research that happens in the infection prevention and control space, a lot of it comes out of from folks that aren't bedside, direct care infection preventionists, because IPs don't have time to publish. They don't have time to design their studies and to, take those interventions and put them down on paper and then deliver them out to share them with their peers. And that's a huge miss for us, a huge opportunity.
Completely agree. I remember one of the rare things I agree with Richard Branson on is he was once telling his senior management team, we've really got to invest in developing and educating our staff. And they're saying, well, what happens if we develop them and educate them and they leave? And his answer was, what happens if we don't and they don't leave?
Exactly that.
I thought, that's actually very good. With an underdeveloped team. And I do actually remember, I think it was a paper from Sanjay Saint and colleagues, where they looked at followership, and they showed that the most up-to-date IP teams actually had the most up-to-date IP practices. So that there was an element of, if you develop people properly, then you're actually more likely to be ahead of the curve from that aspect as well.
And I would further that to say that I'm positive there's a correlation between job satisfaction and retaining IPs that's associated with that as well.
Yeah, I completely agree. So you eventually moved on to trying to develop a calculator based on your previous work. Can you describe how that works? Because I've had a little look at it, and it certainly wouldn't, I'd struggle with it because we don't have some of the data inputs that you're looking at. So if you could just describe how that works and what data you need to be able to put into it, because I think in your most recent paper, you managed to show that actually virtually nobody has enough people in their team to do the work that should be required.
Right, yeah. So the calculator was born out of the idea that in an ideal scenario, every hospital, every healthcare system would do the approach we've just been talking about, a very comprehensive needs assessment. But in reality, that's just not possible, right? Very small hospitals, under-resourced hospitals, or folks that just aren't able to prioritize that time. We wanted to give them a tool to use to try and achieve a similar endpoint, and that's really the idea behind the calculator. So the calculator works as it's based in a ratio, and that ratio starts all hospitals out at 1 infection preventionist per 85 beds. And we chose that because the literature, that's sort of the midpoint of the literature. And then based on the questions that the IP enters, or the answers the IP enters, the number of beds either goes up or down. So recommending you either have less IP staff or more IP staff. It's questions like, do you have a burn unit, a rehab unit, really focused on those high risk areas? Do you have a surveillance program, understanding that if you're doing paper manual surveillance versus having a computer software that is sorting through things and, giving you a list of specific things to look at, that's going to require significantly more time. And so each of those factors is weighted. And, if you start at 1 per 85 and you don't have a system surveillance program, I can't remember what the individual numbers are, but your ratio may drop to 1 IP per 65 beds. And so meaning you need more IPs per bed because it's going to take you longer to do surveillance. The initial version of the staffing calculator that's available now is we're calling it a beta version for a number of reasons. We're very confident in the algorithm, and we're very confident that the risk factors that we've included are predictive of your staffing needs. But we're not confident that there aren't other things that are going to help us to be even more predictive. And so we included a lot of questions in the first version of the calculator that are intended to be investigative to help us build V2 and make it even better. And so you'll see some of that in the paper that we published, that we're trying to understand how do we optimize the calculator. And we've got a very long list of things that we learned when we reviewed the data for the 390 facilities that responded that are, helping us to create a version 2 that I think is going to be even more representative of a hospital's needs.
I mean, because you had a lot of people respond, so that's a nice, rich data set you've got. Can you tell me, quite a lot of the questions when I looked at them were related to you knowing what your standardized infection ratios are. Can you tell me what that does to your requirement if your rate is, say, significantly higher than the average? Do you need more infection prevention staff to actually help implement measures to reduce?
Yeah, we did not include it in the algorithm. So that was an investigational question. Helping us to try and understand that what I think ended up being the most important thing we learned is there a relationship between facilities that report low staffing and HAIs. And and when we started reviewing the SIR data, one thing we learned immediately after the calculator launched is, oh, that's right, critical access hospitals, very small hospitals, probably aren't going to have an SIR because the denominator that they're reporting is too low to be able to generate an SIR. Another thing we learned is not all IPs were able to tell us what their SIR was, and we had some really erroneous results entered into the calculator. So we ultimately went out and utilized a standardized data set of SIRs for each hospital that exist via the Center for Medicaid and Medicare Services in order to really ensure that our data set was as reliable as possible.
One thing that's often struck me is that we often design our program in our facility because we look at what we've got and what we think we need to do. Has any work been done with the management of the organization, so not the infection prevention group, to say what do you want to know and what would you want to concentrate on? And because I used to think, well, actually, if I gave my managers a list of things that we feel we should be doing and put a time on each of them, a whole time equivalent or whatever, and then you add them up and you're way short, I wondered if the best thing to do would be to go back to the management and say, okay, that's what we think we need, and that's what you've told us you might want us to do. Which bits do you want us not to do if you're not going to fund the program?
That's actually exactly how we presented the data, back in 2017, 2018, when we were doing that work, as we provided the senior level management at each hospital with that very comprehensive listing of here's all of the things that, we know we have to do or we think we need to do in order for us to have an effective program. Here's the time associated with it. Here's the difference between the number of IPs we have and the number of IPs we need in order to accomplish this. And the choice really is at that point, do we hire more people or which of these things do we stop doing? And those were very hard conversations.
I can imagine.
But it's a very defensible way to to have that conversation and to increase your staffing. And we were able to significantly increase staffing by
that was the
having
question I
those
was going to ask. Did it
conversations.
work? Yeah.
Mm-hmm.
Okay.
It did. Yeah, it did.
Because
And,
interesting.
maintain.
Go on. Sorry.
Oh, go ahead. I was going to say maintaining that level of staffing over time became difficult, during COVID and, through attrition and all sorts of other things. But at the time we were able to make a really sizable increase in our staffing.
That's really interesting. It reminds me of a poster I saw at IPIC a few years ago where a colleague from Belgium, and Kaluwitz, was asked by a hospital, how many cleaners do you think we need? So she used a method of looking at, if you want to get to 80% compliance using UV dots, Phil Carling's method, you actually need to double your number of whole-time equivalents just to get to 80% compliance, and then handed it back to them. Okay, what do you want to do? And they almost had no choice. So that's very interesting that you got a significant increase because of this, because it's giving it back to the management, because it's the decision they're going to be accountable for. If an accrediting body comes around and says, why aren't you doing this? And the infection prevention team can say, well, we were asked not to do that by the management. So that's fascinating.
Exactly that. And, when you hand off that, to your C-suite, these numbers that seem like, oh my gosh, that's a very expensive ask to be able to add this many FTE. What we've struggled with in the past is being able to say, yes, but, here's the cost that we're going to be offsetting. Here's what we're going to potentially be preventing. Because in the literature, there's not really been anything that shows in a large data set a correlation between a staffing level and healthcare associated infection rates.
Yeah.
And that's really kind of the big aha of this paper, of this project, is that because we were able to get the SIRs and we were able to put those two things together, we were able to see that, yes, indeed, there is a statistically significant correlation between how well staffed you are and your HAI rates.
Yeah, and this is really nice data, because there have been a few papers suggesting that, but this is much more robust going forward. So, and then you can start to put a cost on it, because in your health system, healthcare is so well costed, you can actually demonstrate real savings, can't you? Some of us might struggle a little bit more with that. Tell me, do you
we
think...
argue about it still here.
Oh, sure, of course.
Yeah. So.
Well, how do you know you would have prevented it? Is an argument, a discussion I've had a number of times.
Many times, yeah.
Do you think this model would work outside of the USA?
Absolutely. The model and the idea is completely agnostic to location. The factors that are selected and the data elements that are used, I think, need to be made specific to the healthcare setting. We've used the same model we've created calculators for ambulatory care settings, long-term care settings, et cetera. And, it's all about just taking a look at, in whatever your geographic location is, or your care setting, what are the things that change the amount of time an IP is going to need to spend doing their routine daily task. And as long as you're able to identify those, the method should work. And really, it could be applicable to anything in healthcare. That same idea of how many hours a day does it take to do the things that we need to do.
Yeah, fantastic. Will you make it available, do you think, to non-APIC members going forward? Because I can think of many developing countries would find it extremely useful to start setting a benchmark for where they are and what they may need to move. They're not going to get the same numbers that you or I might get, but it might certainly help them pick off the low-hanging fruit in their own areas before they can move on to more problematic areas.
Yeah, absolutely. We, the paper does include all of the data behind the algorithm in order to, for just that, to be able to share so that other folks can reproduce the model and tweak the factors and get the same effect.
Fantastic. Well, it's really nice work. I look forward to seeing version 2 and papers that come out afterwards. Do you think you'll have to do a significant amount of tweaking before you can release? What's the timescale?
It's a lot, yeah. So version 1 has one single algorithm. Version 2 has 16 algorithms behind it.
Okay.
And yeah, so we've decided to separate out the hospitals based on bed size, because what we learned is there is a baseline number of IPs that or of IPFTE that's really required to keep the lights on regardless of the size of your hospital. And so when we talk about very small hospitals, the algorithm changes to reflect, at minimum, we need this number of folks. And so we're working now with our IT team. They're actively building. I don't want to predict release date because then I'll be held to it.
I won't do
that. As soon as possible.
Yeah, I wonder how well it would work in a hospital with, say, 3,000 beds and 200 ITU beds, because we've got a couple of like that over here. So, yeah.
It'll tell you need a lot of IPs.
I had a feeling it might do.
Yeah.
Well, thank you so much, Rebecca. I've really enjoyed chatting to you about it. I look forward to reading more papers coming from your group, and I'll highlight all the papers that you've written so far on this subject in the information that we send out with the podcast. So thanks very much for this. I really appreciate chatting to you. It's been fascinating.
Thanks so much.
Bye-bye.